Good evening, everyone. Welcome to our second live back in-person lung cancer living room. Thank you all for joining us tonight. We, as I said last month, couldn't be more thrilled to be back in person, to be able to see all of your lovely faces and share hugs and food and wine and great conversation. As many of you know, tonight's conversation is going to be around palliative care, and we're going to tie in some caregiver stuff sort of at the end of it. And so we are more than thrilled to have Dr. Millie Das here to come and speak with us. She is Chief of Oncology at Palo Alto VA, and she's on faculty at Stanford as an associate professor. She did a living room about a year and a half ago, but it was during COVID and it was virtual, and I think it was around or on Veterans Day.
Yep.
And talked about a lot of the work that's going on in veterans. And of course, those of you who know GO2, and I know all of you do, know about the special work that we do within this population, particularly around screening and early detection, but of course also along the entire care continuum. So thank you so much for being here. I want to jump into the conversation. Our hope tonight is that everyone will, I think when we say palliative care for the lay person, particularly for those who are newly diagnosed, it's a controversial sort of conversation, mainly because it's misunderstood. So we really want to make sure that everybody that walks away today understands what palliative care is and what it isn't, right? And so with that, let's kind of jump right into what is palliative care. What do we mean when we say it?
Yeah, I think it depends on who you ask and the context in which it's brought up. I think most practicing oncologists practice some form of palliative care. Of course, every time we see a patient, we ask about symptoms, we ask about quality of life. We try to do whatever we can to try to provide guidance and medications and support to help with those symptoms and things that our patients discuss with us. So I do feel that we all practice palliative care. Palliative care as a specialty is just basically the people who provide that level of expertise in symptom management have extra training. And so when we do prescribe medications, let's say for pain, and it's not working and we could use some help, that's when we refer to our palliative care colleagues to provide additional sort of outside of the box thinking. And these are a team of professionals who, again, sort of have this extra layer of training and expertise in symptom management, including pain, but other various symptom management. And they help co-manage with our patients the various symptoms that may arise as the illness, trajectory continues for patients. And so I think it's a really useful thing. Not every facility has a palliative care department. And so it is important to understand whether, your facility, wherever you're seeking care, has palliative care available, how it's being offered. Certainly at Stanford and VA, I've seen differences in how palliative care is delivered. I think in the optimal model, you would have palliative care sort of embedded into the lung cancer clinic. It's not always possible due to staffing or other issues, and so these are people that I have on my kind of speed dial on my on my cell phone. So when I have a patient and I'm trying to help them and haven't maybe figured it all out, I'll call them up or text them and just let them know, hey, do you have any thoughts on this, or I'm going to send this patient to you, and then they facilitate getting that patient in quickly and being able to address their concerns. I think now that we're doing a lot of video visits, it's also facilitated palliative care in a lot of ways. And so I think, again, it's just for different institutions, for different people, for different providers, it may have different meanings, but I think the broader sort of goal and definition is really focusing on symptoms and managing symptoms as best we can.
I think it's important to kind of talk about like what those symptoms might be, because I think quite often people who are diagnosed with lung cancer, when they do have symptoms, they're maybe not reaching out to their healthcare providers for fear of being taken off drug. If I complain about X, right, they're going to take me off. But why is it important that they do complain about X?
Absolutely. I mean, we know all the drugs that we give, oral, IV drugs, they all have the potential for side effects. And we always have to sort of balance the quality of life with obviously the anti-cancer effects of all these treatments that we're offering. I mean, there's no point in giving a drug if it's, landing you in bed all day and you're, feeling miserable. And so it's this balance, and we need to achieve that balance by thinking about what can we do to make this more tolerable? Is this an expected side effect? Could there be something else going on? We worry about lung cancer progression as a cause of symptoms as well. And so a lot of different things that we absolutely need to know what you're feeling and really try to think about how can we manage this. I was just telling a patient today that, a lot of these oral chemotherapy drugs, they come with specific dose recommendations, but that may not be the right dose for you. And so, we have to be mindful of dose reducing. I oftentimes now start patients on lower doses and sort of dose escalate depending on how the patient's tolerating. So there's different ways to, trying to figure this out for individual patients. And I think it's just one of those tricky things, that we need to work out together. But we absolutely, as oncologists, we want to know what you're experiencing. And it's not that we're going to take you off drug. It's really about trying to manage the side effects, thinking about dose reduction strategies, thinking about maybe giving a break. Just depends on what the symptom is, how alarming it is, what the risks are associated with it.
So I think, and I know there's a few people in the room tonight who have experienced positive results with palliative care, but I know that there's also people who have said, no, I'm not going to talk to my doctor about that. And I want to kind of turn to my friend Larry over here and ask him about his experience and how it has impacted your care.
Palliative care has been very positive for me. I have to admit that my original relationship with palliative care was as a phone buddy, more do as I do.
Or do as I say?
Do as I say, not as I do. Yeah. I did see palliative care early in my cancer life. We collectively decided I didn't need it at that time. Yeah. And then I had an automobile accident. I passed out, and my family took me by the hair and dragged me into palliative care, which has turned out to be a really great experience. I have the good fortune of being in touch every 4 to 6 weeks with a nurse practitioner in palliative care who helps me with some mental adjustment. I just started a new targeted therapy, and we had some discussions about what she might be able to do with me to help me with side effects. Fortunately, those side effects haven't occurred. But if I were to characterize palliative care, it's really helped my frame of mind for the last several years, just to know that if I need something, I have that available.
Dr. Das, do you notice that sort of as a trend in the folks that you work with, that also?
Yeah, and when you talk about sort of the mental, so when we talk about symptoms, it's not just physical symptoms, but mental symptoms. And, I think sort of it's an all-encompassing sort of definition. So it may shift over time. You have a palliative care provider, and you may have gone to him or her for a particular reason, and then you have that relationship, and as things change, as your treatments change, new things come up, and there may be times where you focus more on some of the mental struggles around your treatment and diagnosis, and other times where you're focusing more on your physical struggles. And I think it really does evolve for everyone differently throughout time. But what's nice is it's that kind of same person or care team that's there for you, and they're there to, I use the word co-manage because there's a fear that you go see palliative care, they prescribe you something, and they're not talking to the oncology team, and that's not at all the case. I mean, they're always constantly keeping us in the loop, asking us, is this okay? And, and so it is, we are really working together as a team.
I really think they're augmenting what the oncologist is doing.
I agree.
Yeah, working together. How many people in the room always sort of assumed prior to your diagnosis, and maybe even at the beginning, that palliative and hospice or end-of-life care were the same thing? Yeah, and I think it's pretty standard, and I think we hear that on the helpline a lot, in particular when we're making a recommendation that the folks call their healthcare providers or their medical oncologists to discuss this palliative care option. So, Millie, you mentioned that it's not offered everywhere. What does that mean for a patient who is maybe in a place that it's not offered? Are there still options?
Yeah, I mean, I think as I started out, again, when you're seeing an oncologist, they're practicing palliative care. And so that is foremost on our minds as we're thinking about managing treatments and side effects and quality of life. And so that is something that we're all really concerned about, and we are all trained to be able to do. I think, as Larry put it, the palliative care sort of augments what we are already doing in the oncology visits. Just because as a specialty, this is a fairly new specialty, It hasn't been around as long. There just aren't as many palliative care trained providers, I think, that we, as we need in this country. And so depending on where you are, academic centers will have palliative care, but community practices may or may not. And again, it kind of depends on where you are. And so I think finding out, what services are available, what is, sometimes there's long wait times. There may be other options. And I think, again, with the COVID causing us to shift from in-person to video, I think that's actually been helpful for palliative care, because I think it is allowing people to be seen. Let's say you live here, but you want to be, there's not a palliative care provider closer than, 50, 60 miles away. You can still maybe make an appointment with somebody far away and do a video visit with them. And so I think that's now becoming more, I'm seeing that a lot more.
Is it common that patients can self-refer to palliative care?
I believe that they should be able to, yes.
In the real world, it doesn't happen.
Yeah.
The caregiver, as a caregiver and as a palliative care member at Packard, I know this doesn't happen.
Yeah.
And it's sad. And we're living in, a great place. But we have many mutual phone buddies who literally, we've been on the phone as the patient is dying, and there has been nobody else. And that to me is just awful.
Yeah.
And I wish that palliative care was introduced as part of the whole first picture, as part of a team, and not brought in when there's a crisis, which I think happens a lot.
I fully agree with you. Yeah.
Thanks, Thayer. And both you and Larry have mentioned phone buddy. So just for those, and I know I've mentioned it in the past, but for those who may not know what you mean when you say phone buddy, would you mind explaining that?
In the beginning, when Larry was diagnosed, we didn't have anybody to talk to that had his same symptoms, his same diagnosis. Where do you go for that? And so Miranda, our foundation, has, put us in touch, and we act as sort of just good listeners, I guess, would be the right thing, and to help support them. And I guess over the years, we've had, 12 or 15, 20, I don't know, a lot. But what's been really amazing to us is that so many of them do not have access to palliative care, and that they're, once their diagnosis has, taken a turn for the worse or whatever, we're in contact almost weekly, if not daily sometimes, and there's nobody else. And that, that's a difficult position, obviously, but also a really important one, because you're alone enough in your diagnosis, and it's nice to be able to reach out to a friend or someone else and say, hey, this isn't working, I need some help.
Yeah. Thanks, Thayer. I appreciate that. I mean, I couldn't agree with you more that Miranda does a fantastic job. We've talked a lot about the sort of quality of life and side effect management and how important that is. We just touched on sort of the mental health piece, and we talked, Larry, I think you just said it, or Thayer, you did, that this diagnosis can be incredibly isolating. And then when we threw COVID in the mix with all of that, it was even more isolating, right? We do have programs like the Phone Buddy program to make people feel less alone, hopefully. I mean, that's the goal. But depression and anxiety are a real thing, and I think also quite often stigmatized, right, as something people don't want to reach out about. Can you talk a little bit about the importance of sort of maintaining quality of mental health as well as side effect management?
Just to sort of destigmatize it, it's really common and it's almost expected. I mean, you have this life-altering diagnosis and all the uncertainties that are associated with that. And so we do try to talk about that and, really understand every individual's social circumstances, their own mental health history, how they're coping, how they plan to cope. There's a lot, and it does change over time. And I think, these days we have so many different ways to approach mental health. And so sometimes it's just about connecting someone to a therapist or just someone to talk through a lot of what's going on. There are medications. I have a lot of patients who don't want to start another medication, and that's perfectly fine as well. But we talk about the different options, and we really do try to spend some time, how are you dealing with this? How is your family dealing with this? How how can I help and support you? And, at Stanford, we started sort of a questionnaire that we're asking all of our patients when they check in, and that kind of triggers extra questions. Again, just today, I had a patient who, sort of answered a lot of the questions in a way that triggered something to me in the chart that made me say, oh, well, I need to really think about that. We're gonna, of course, talk about the scan, we're gonna talk about the treatment, but I'm gonna focus, some extra time on this as well. And so then I go through the extra questions and I ask the patient, what support services are you using? And then I hear, oh, I have X, Y, and Z. They're super helpful. This is great. And then I feel also reassured. Yes, even though this is something that they brought up in the questionnaire, it's something that I know that I'll kind of go back to later on and know that I've addressed this. And I actually think it's great that it's kind of a forced trigger for us to have a discussion and to think about the resources that are available and to be able to offer them. Not every patient's ready to accept all the services, but again, just having that conversation about this is what we have available. When you want to, when you're ready, send me a message. I'm happy to put in a referral. Or maybe we can talk about these things and talk about, what are things that we can do to help. So there's a lot of ways that we can sort of talk about mental health coping as a patient is dealing with their diagnosis and their treatment.
Yeah, and I can't help but think that even if there's not active, palliative care at any one center, that a medical oncologist couldn't help a patient to sort of navigate through some of these challenges outside of coordinated palliative care program.
Yeah,
right?
Absolutely.
So it's worth the conversation.
It absolutely is, and sometimes we also, talk to our social workers about access to support groups like this, and and support groups aren't for everyone, and some people really benefit from individual therapy. Other people, like the idea of support groups. There are support groups, throughout the country, and so connecting people to the resources and really, starting to talk about, what are the things that we can do, what are the things that you're open to, and really trying to tailor that.
So one of the other pieces to this, Millie, and I know you and I had talked about it, and you're very familiar with the SHAWL study, which is looking at sexual health, which is also is an uncomfortable conversation for a lot of folks to have with their partners, let alone anybody outside of their safe space. Why is this also an important sort of?
Yeah, I think it's, again, it is an uncomfortable topic. A lot of people it's not brought up naturally in conversation. I think patients don't necessarily feel comfortable bringing this up. And so I do think it was an important study, and, just highlighting the high rates of sort of sexual dysfunction among lung cancer patients undergoing treatment, and just addressing it and trying to come up with ways to address it and treat it. And I think it's again, you have a certain amount of time to do a visit, and there's maybe, like a whole list of things. You want to, of course, get to the patient's questions, and then we have our own sort of agenda, like let's make sure we looked at the scan and the labs, and so it's tough. And then I think, unfortunately, a lot of the sexual questions, the mental health questions, they get kind of pushed to the end. And so I think always starting the conversation, I think a lot of us do try, like, what is foremost on your mind? It may not be, number one on, what I thought we were going to discuss, but that's okay, because ultimately this visit is about you and making sure that we address, what you are here to, want to talk about. And we'll get to the other things, but I think that is important. And so I have had some patients who tell me, well, I'm wondering, is there some barrier protection that I'm supposed to be using? What, is this something that I can pass along to my husband or wife or partner? There's just, questions that people have, especially when they're first diagnosed, around sexual health that I think they're afraid to ask. But I do think it's important, and I think we all could do a better job of trying to address it. I think that's what the SHAWL study brought to light, is that there's a high prevalence of this. We're probably not doing a good enough job of asking our patients and knowing how to refer them and who to refer them to get help.
Yeah, no, I couldn't agree more. Not all clinical trials are drug related, right? Sometimes it's just answering a few questions to help us glean insights. So go ahead, Jennifer.
Yeah, I think one of the big focus areas for GO2 is making sure that everybody has an opportunity to participate in research in some way or another. It's so important, and SHAWL's a good example because it was done in our lung cancer registry, which is all patient-reported outcomes, and so it's just asking the patients and caregivers, there's caregiver surveys as well, questions about what's your experience and what are things that we can learn about real-life experience, what's going on in your lives that GO2 and others in the medical community can really address. And so that makes it really impactful. SHAWL's been submitted for publication now, but you described it perfectly, and that what it really brought to light was the very high prevalence of women's sexual health for people who are on different types of lung cancer therapies. And it was something that really hadn't been well detailed before, because no one asked. Yeah. So we really very much encourage everyone to either participate in a clinical trial if it's an option in your treatment journey. It's a conversation you should be having at every decision point of, does it make sense to go on a standard of care? Does it make sense to consider a trial at this option? Why or why not? And we have some great navigators on our Lung Match program who are happy to help you talk through that decision-making process. But if that's not the right option, you can still participate by things like the Lung Cancer Registry, things like data collection and contributing to the conversation so that we can learn more.
Great, thanks, Jennifer. So we've talked about what palliative care is, right? It's there to relieve and manage symptoms and side effects, both physically and mentally and sexually, right? That is the purpose of this. But Dr. Das, is there data outside of what we even know from the SHAWL study that shows improved outcomes in people diagnosed who have palliative care as part of their normal care routine?
So this was a study that was actually published in the New England Journal back in 2010, so a while back. I actually remember going to ASCO and hearing this study presented. It was sort of groundbreaking at the time, because here is an intervention that provided a survival benefit to lung cancer patients that was really not your typical intervention in the sense of like an added drug or something like that. This is early palliative care, so introducing palliative care at the time of diagnosis for a patient who has advanced or metastatic lung cancer. And sort of as a randomized study, so integration of early palliative care versus routine standard of care, going through your cancer treatment. And what they found was a 2-month survival benefit for those patients who were introduced to palliative care early on. This is now integrated into our current guideline recommendations. We have NCCN guidelines. I was just reviewing them recently because we do iterations of them every few months, and it was great to see that it's not just integrated into the NCCN guidelines for advanced stage, but really for at the beginning of a lung cancer workup and diagnosis, it's there. And I love seeing that, because we know that patients who are offered palliative care early on in their treatment course are going to do better. And this is despite the fact that towards the end of life, patients who were introduced to the early palliative care option pursued less aggressive therapies. And so kind of wrapping your head around the fact that you can be pursuing palliative care with a focus on quality of life and symptom management and actually live longer with that focus. It was groundbreaking at the time, because I think we're just always used to seeing data about drugs that improve survival, and so it was just exciting to see intervention this simple. Maybe I shouldn't call it simple, because depending on where you are, again, it may or may not be feasible, but if we can integrate this early on, we absolutely should, and it's been proven to provide better outcomes for our patients and better quality of life, better mood reports from patients. So there's a number of different benefits from this.
So now I want to kind of move into the more sensitive area, the more scary area, or what people are more fearful of. And it's also a hard conversation to have, not one that's limited to a lung cancer diagnosis, right? This really goes for anybody at end of life, regardless of what has brought them there. Can you talk a little bit about hospice care?
Yeah, so hospice is sort of on the spectrum of palliative care, but as we talked about, palliative care is sort of a bigger category. Hospice is really a focus on end-of-life care. Typically, when we think about hospice, and we offer patients hospice, we're usually thinking about a life expectancy of 6 months or less. So, as you all know, we're not great at estimating, and I certainly have had patients who go on hospice, and we get to the 6 months, they're still doing great. And then we extend hospice or we discontinue hospice. It sort of depends on the situation. It's really sort of an acknowledgement that, a patient has been on therapy and they may be on, third or fourth or, another line of therapy that, may or may not work. And we're worried that the cancer is progressing to the point where, we would not be surprised if it took that patient's life in a 6-month time frame. Again, 6 months is somewhat arbitrary in the sense that we can't with any certainty predict, but that's sort of the requirement to be enrolled into hospice. There's also sort of a misconception that you have had to agree to sign a do not resuscitate order to be on hospice. That's not true. The hospice philosophy typically, will align more with the do not resuscitate order, but that's not something that is a requirement to enroll into hospice. So it's a conversation. It's an additional support for patients. So when we think about hospice, there's inpatient hospice, there's home hospice. There are various hospice agencies throughout the country. And when we put a referral in, typically it's with sort of a third party. I always tell patients, if you don't like the hospice agency, if it's just not working out, there are other ones. And so there are options there. And it's not one of those things where you sign up and you're sort of stuck with it and you have to do a certain number of things. It's really just there. It's an additional support team there to help manage your symptoms, to help you with end-of-life care planning at home. They can make up to usually 2 house visits a week, but they're not going to force themselves into your home if you don't want them. And so I think that's another thing when I have patients tell me, I'm not ready, I don't want anybody coming into my house. You don't have to invite anyone into your house. And they're just basically when you need them. And so they have that 24/7 access, which I think is great for patients to, as things arise and maybe their provider's not available, it's 3 a.m., what do we do? Do we go to the emergency room? You can call hospice. They oftentimes can help manage symptoms from your home. They can, actually go visit you and provide you with whatever relief you need. And so it is really great. Different hospice agencies sort of function differently. I'll say at the VA, we are able to offer home hospice even at the same time as offering cancer treatment. So we can have patients be getting chemotherapy or radiation therapy and continue to receive home hospice. That's sort of an exception rather than the rule. Most of the time, in order to be enrolled onto hospice, you have to have, basically stopped your treatment. And so I struggle with that because I have patients both at Stanford and VA, and I do find when I'm able to have patients receive home hospice while they're on therapy has been really helpful, but it is a sort of insurance mandate.
Let's talk a little bit about caregivers and, as my experience, the support that's sort of lacking for these amazing people who are out there trying to support their loved ones but also have their own sort of set of needs. What does that look like in your practice?
I know. I mean, this is something that's near and dear to my heart because I feel like caregivers feel like they can't say anything because it's their loved one who's going through the diagnosis and the treatment, and so they can't bring up their own struggles. And I can see this. It's, as an oncologist, I notice this, and I want to include caregivers in the conversation, but I can see the reluctance in them even sort of complaining or bringing up their own concerns. And so I think when you're talking about the lack of support, there's so much, again, that we're trying to accomplish, and then, this is another thing that goes to the wayside. But I can't tell you how critical caregivers are in a patient's, sort of treatment trajectory and their kind of care. When we think about the drugs and things that we're offering to our patients, the first thing I think about, what is that patient's caregiver support? How are they going to reach out for help when they need it? Last thing I want to be doing is giving a treatment and then saying goodbye and, and having these, patients leave and having, and then not knowing who to call and having no one to call when they are not feeling well. And so that is something that we actually take into consideration when we're thinking about treatment, because we certainly don't want for people to feel like, oh my gosh, this is something my doctor gave me and I don't know what to do, I don't know who to turn to. And so we ask about caregiver support. And then honestly, I've seen a lot of the times, our caregivers have jobs and they have other responsibilities. And how do you deal with that when you're, having to bring your loved one to doctor's appointments and scan appointments and, it's just the list goes on. And I think it's really hard. I always try to put myself in my patient's shoes or my patient's caregiver's shoes, and I'm thinking, oh my gosh, like how would I do this? And I think we don't have enough resources. I wish we did, and I think it's something that we need to work on. We need to be able to relieve caregivers to allow them to, kind of continue to live their lives while also supporting their loved ones. And I just think it's one of the things that we just don't have enough resources out there.
Yeah, I agree. It's a challenge there. Do you have any thoughts?
From the beginning, it was pulling teeth, obviously. And there's a lot of, how are you doing? I'm fine. when he's not. And I think the thing that has been the best for me is forming the group that surrounds Larry, the babes, and other people. I get their perception and their questions, and they all pick up on, no, he's not doing fine, you know, what's going on. But I think as a caregiver from the beginning, I mean, I did this with both my parents, and I was the caregiver. I think I've learned that you're only as strong as you are. I mean, you can't help somebody else if you don't ask for help. So you reach out to your friends in your support group. And, you know, what Larry and I both realized from the beginning is you know, we have dear friends who can't cope with the lung cancer thing. I mean, they don't know what to do with it. And for me, that's been really hard to realize that who I thought could be there can't be for their own reasons. And so you reach out to other people that can. So I think, you know, the foundation's been amazing in giving me tools to help myself be a better caregiver and to be more involved in the process. But, you know, this whole palliative care thing is one of my favorite subjects, only because I was involved at Children's Hospital with caregiving. And I realized that as part of the palliative care team and as a caregiver, you know your patient better than anybody. And, you know, you need to go to those appointments because the questions that they're asked, you may be able to better answer than they can. And I find that in so many instances. And, you know, even with end-of-life care, I had kids who said to me, my mom and dad don't get it. I'm ready. I am ready to go, you know. And that's a really hard thing for a parent to hear. But if it's presented enough, they can finally hear it. But it's hard for anybody to say, you know, I've had enough or whatever, or I don't like the way I'm feeling or whatever. But as a caregiver, you're kind of the second voice in the project, I guess, on the journey.
I mean, I think a lot of patients feel like they're letting their caregiver down if they decide, you know, I don't want any more treatment. And I've seen that time and time again. And I think it's really powerful when, you know, you have these conversations and then you know, bring the caregivers back and you let them know. And you know, and of course, the universal reaction is absolutely not. Like, you're not doing this for me. And I think just reminding people, you know, to feel comfortable having these conversations. Sometimes it's going to be in the doctor's office. And I think that was one of the struggles with COVID when they were restricting caregivers in the office. So trying to get them in on FaceTime or on telephone, because I think it's so critical. You know, I can't tell you, you brought up, you know, when we talk about how are you doing, you know, mentally, physically, and the patient says, I'm fine. And the caregiver says, what do you mean you're fine? You know, this and they list a number of different things that happened in the past week, and you know and so it's like, oh, okay, and then you know the patient's like, yeah, actually that did happen, and so it gives us a more complete picture of what's going on, and it also allows the caregiver a voice to really bring in their concerns and bring up questions that maybe the patient had that didn't feel comfortable asking, or maybe the patient didn't even realize that their caregiver's thinking about these things, and because, you know, maybe there's a hesitancy in talking about that. So I do think just having it be sort of the norm where we invite caregivers to join in the conversation, it really goes both ways. It's so helpful for us. I think it's helpful for the patients and the caregivers as well.
Thanks. We talked about a lot of things tonight, this evening. What is your hope that people take away from this conversation?
One of my hopes is just to sort of normalize palliative care and really encouraging our patients to feel comfortable talking to us as their care providers about whatever is on their mind, and knowing that we are here to listen and not just think about the cancer and the treatment associated with the cancer, but really we're looking at the whole you and want to address all those other things that maybe you don't want to bring up, or you think that we may not know what to do, or you know, we have a lot of resources these days. We send a lot of our patients to see other specialists, and palliative care is another specialty. And there's this, I think this whole co-management model, and I think again, sort of normalizing what palliative care is, and then talking about hospice as a tool to really prepare for end of life, and something that nobody likes to talk about, but I think is really critical. And knowing that we want to be there to support you through this whole process, and it is difficult. This is a difficult journey and a difficult process, and there's a lot of different things that will come up along the way, and just knowing that we are on your side and we want to do whatever we can, and not just for you, but for your loved ones as well. I think, yes, it's not just a disease that you're carrying, but all the people around you are being affected by this, and taking time and space to talk about that, I think, is really important, and we want to do that, and I hope that that's something we can all continue to do, and I would absolutely welcome that from all of you. Yeah, so thank you.
Thank you, Dr. Das, for coming and talking to us today. We cannot tell you how much we appreciate it. To all of you watching live, all of you in the room, the entire GO2 staff, and of course our supporters, which is a very long list of people who year after year after year support this program because they see the value in it, just like we do. Amgen, AstraZeneca, Boehringer Ingelheim, Bristol Myers Squibb, Daiichi Sankyo, Eisai, Foundation Medicine, Genentech, Janssen Oncology, Merck, Mirati Therapeutics, Novartis, Regeneron, Sanofi, and Takeda. Thank you all from the bottom of our hearts. Until next time, see you guys soon.
So I'll be brave if you're brave. I'll be brave, but only if you're